Welcome to Health Focus with HCA Virginia, where we focus on health concerns that are important to you and your family.
Hi, and welcome to Health Focus, brought to you by HCA Virginia. I'm Joanna Fazio, I'm your host, and I'm here today with Stuart Fruman, a radiologist at Reston Hospital Center. He's the director of the Women's Imaging Center, and we're going to talk about prevention and diagnosis of breast cancer. Also later on in the program, we have a breast surgeon, Jane Hanscom. And quickly, I'd like to acknowledge the HCA Virginia hospitals in our area, Reston Hospital Center, coming this spring, Spotsylvania Regional Medical Center, Dominion Hospital, and coming in about 5 years, Stone Spring Medical Center in Loudoun County. We also have the Reston and Fairfax Surgery Centers in our area. So Dr. Fruman, if we could just start with, when should a woman actually start having mammograms? You hear all the different ages, and I think 40 is the most consistent one I hear, but every once in a while I hear 35, and when I was looking through all my insurance information, it said that I could have one at 35 and then wait until 40. So what do you all say?
The American Cancer Society's recommendations are a woman of average risk or no increased risk should start at age 40 with annual screening mammography in conjunction with an annual clinical breast exam.
Okay. And then if she does have a family history, say mom or sister or aunt, then how should that be changed around? Earlier?
Yes, for sure. Women who have increased risk, and risk can be defined by genetic risk factors or just having family history, mother, sister, aunt, etc. There are several different criteria in which you decide on how you calculate someone's risk, but as a general rule, you should start screening at least at age 40, if not earlier. Some women should probably start screening potentially as early as age 30.
Okay. So if you had a mom who had breast cancer at 40 and she was diagnosed, would you think 30? I know at one point the formula was explained, but there are so many complicating factors that probably would confuse people rather than help them at this point.
The general formula that's often used or quoted is 10 years prior to the initial diagnosis of say, for example, their mother or sister, especially if it's a premenopausal situation.
Okay. So I know that at the Women's Imaging Center, because I've been reading about it before we did the interview, they have digital mammography. And you keep hearing about digital mammography advertised all over the place and who has it and who doesn't. Can you tell me what the actual difference is and how it helps you as a radiologist find things, or how it would help me catch something earlier if I did happen to have breast cancer?
Sure. Digital mammography is fabulous, a great tool for the radiologist. It's not the standard of care yet because obviously not everyone has that. Film screen mammography still is very good. Digital mammography, some of the strengths or benefits of it is, number one, less radiation to the patient. Number two, it's a digital image. So like a picture that you take on your camera, a digital image, you can manipulate the picture to enhance or magnify or look in or change some of the window settings to better see through the breast. With film, the exposure that you get is the exposure that you get. You can't go back into the dark room and readjust the image. So if the image isn't perfect or isn't good, oftentimes they have a higher repeat rate. You have to repeat those images a little bit more. As far as comparing them side by side, National Cancer Institute did a big trial back in, I think it was around 2001, the DMIS trial, the Digital Mammography Imaging Screening Trial, which compared digital screening with film screening mammography. And what they found was that film and digital were equivalent in detecting breast cancer in the general population. However, certain populations, particularly women with dense breasts and women younger than 50, digital definitely had some advantages in detecting some of the earlier cancers.
Okay, so, and I know that I hear from, friends and my mom, if they've had film and then they switch to digital, is there sometimes kind of like, because you can see so much more, they might need to come back for additional, or just you might need to look into more things, just because it's kind of like comparing a picture from when you had those old negative strips versus like a digital picture, and you can see so much more, but it's probably nothing most of the time.
Yeah, a lot of times when patient makes the transition from film to digital, the resolution or the amount of detail that you can see is much greater, and so sometimes you may see things that you didn't see on film, and so there may be a little bit higher callback rate for some patients, for sure.
Okay.
And certainly at our Women's Center, all we have is digital mammography.
Okay.
We've had that since 2006.
And then on the same lines of imaging, you hear about women getting breast MRIs more and more, and what does that do in difference to mammography? At what point would someone be recommended for an MRI?
Well, MRI as a general tool is not recommended for screening in the general population. The only thing that's approved for screening for breast cancer is mammography. Ultrasound can be used as an adjunct to the mammogram for sort of problem solving if there's an abnormality. In the setting of breast MRI, the National Cancer Society came out in 2007 with new screening recommendations for who should be screened for breast MRI. It's a small subgroup of women, and they are women who have the BRCA1 or BRCA2 gene, first-degree relatives with the BRCA1 or CR2 gene carriers, women who have had radiation therapy, usually for Hodgkin's disease to their chest or breast area, and also patients with an overall lifetime risk of 20 to 25% or greater chance of developing breast cancer in their lifetime. That's sort of the general group of patients or high-risk patients that should be screened with breast MRI.
Okay. All right. So I think last year Christina Applegate went through, she was on Oprah and she was on everything else, talking about how she did have the BRCA gene, but she also did have breast cancer, but she caught it through, I think when she found out that she had the gene, she was getting breast MRIs every year, and that's how she found it. So it caught a lot more national media attention, I want to say, after that. So I'm sure people are wondering, is that something I can just ask for? And then also, who gets that? How does it get, so I guess it's good to hear that it's out there at least. And it's something that you have in your office, right? Right.
We have breast MRI available to us on the Reston campus. We have the high field strength 3 Tesla MRI scanner with the latest software and hardware, and so we have all the abilities on the Reston campus to not only diagnose but treat women with breast cancer. Okay.
So if you could just walk me through, because I haven't had a mammogram yet, I'm not old enough, so, but if you could walk me through how the whole process goes. If you come in and then you just go straight back to the screening room and they put you in the machine, and then afterward, does someone just call you and say, looks good, or what happens if you do find something?
So first of all our technologists are women mammography technologists. You'll be greeted by one of them. You'll be escorted back and given you a gown to change into. You'll change from your waist up, and then you'll be brought into the mammography room. You'll stand in front of the mammography machine, and the X-ray technologist will explain to you what they'll be doing.
Okay.
They'll position your breast in the mammography machine, and it requires having the breast compressed for a short period of time. And they'll get 2 pictures on each side.
Okay.
Properly performed, the mammogram should not be painful. Okay. Some women do have extremely tender breasts, and they may experience a little bit of discomfort, but it shouldn't be painful, and even if there's a little bit of discomfort, it should be for a brief period of time. So in the screening setting, you have your mammogram, and then you leave and go on your way. Later that day or the next day, the radiologist will read or interpret the screening mammogram. Once the report is read and the report is generated, a letter will go out saying your mammogram is normal, and that goes out usually within a few days of your exam.
Okay.
If there's an abnormality, then you would get a phone call from our nurse at the office. Now, when we're interpreting a mammogram, we consider the breast as one organ. So most women's breasts are essentially mirror images of each other. So if you hold your hands up back to each other, you can almost overlay the mammogram on each other. And you look for areas of asymmetry, we look for masses, we look for what we call areas of architectural distortion, microcalcifications, basically areas that don't look symmetric to the other side.
Okay.
In those situations, you get a call back and from our nurse and say, the radiologists are in an area that may be abnormal. We'd like you to come back for some additional evaluation. Now, most of the time when patients come back, the area is nothing. It may be overlying breast tissue. We get basically spot pictures. Basically, it's repeating the mammogram but with smaller paddles, either for magnification, to look for small microcalcifications, or a paddle to sort of push out possible areas of masses or architectural distortion.
Okay.
And excuse me. And so, as I said, most of the time it ends up being nothing. If it ends up being something on the mammogram, we oftentimes have ultrasound available to us to look for abnormalities as well, to see if the mass is an ultrasound, is a cyst, and you can tell a patient, oh, the mass is a cyst, don't worry about it, or the mass is solid and may need a biopsy.
Okay. And is the biopsy something that you can do? Is it something that you have to go to the hospital for, or you can get done outpatient?
The biopsy is done as an outpatient. It's all done with local anesthesia. Sometimes they're done with ultrasound guidance. Sometimes they're done using what's called stereotactic biopsy or mammogram guidance. Basically, for the stereotactic, which is usually used for microcalcifications, it's a special table where you lie on your stomach. The breast hangs down through a hole in the table, and a special mammogram compression device, and there's a computer attached to that device. And when you find the calcifications, the computer tells you where exactly you put your needle.
Oh, okay.
And then you put the needle in, you sample that tissue, the tissue goes to the pathologist, and then we put a little clip in to mark that area.
Okay.
And then similar with ultrasound, we use ultrasound to guide us as we insert a needle into the breast, and we sample the tissue and we send that to the pathologist. The goal when we're doing our biopsy is not to remove the remove the area of potential abnormality in its entirety, but to get a good representative sample for the pathologist. If it comes back cancer, then more definitive treatment is needed by a surgeon.
Okay, so then that's when you would refer to someone like Dr. Hanscom, who we're going to have on next.
Exactly,
Okay.
exactly. Now getting back to breast MRI, as you mentioned, for screening, breast MRI also has a very important role once a diagnosis of breast cancer is made.
Okay.
Because in those settings, breast MRI can look for other sites of cancer in the same breast or the other breast. And sometimes even by imaging, mammography and ultrasound, the initial imaging may underestimate the amount of tumor. Breast MRI may actually show that there's a much greater amount of tumor and help to change or guide the surgeon what extent of surgery may be involved.
Yeah, I think in one of the other times I was talking to one of our breast surgeons, she said before she schedules a surgery, she always has an MRI done so that she can, make sure that she gets everything.
Exactly.
And then after someone does go through their treatment and is in remission, do they come back for MRIs or mammograms or both? Is that, you hear about people going back for CT scans to find cancer in other places,
Right.
but is that what they can expect afterward?
They should certainly continue to screen with mammography, and then in certain situations they should, or they may need to screen with breast MRI.
Okay. I guess I'm getting the wrap-up signal. So we've learned so much, though, about what to do beforehand and get screened, and it seems through all the different nonprofits, the message has really gotten out there with pink ribbons everywhere. So hopefully it's making your job a little bit easier, getting women in for their screening and catching it earlier also. So thank you so much for coming on today.
Thank you.